Okay. I'll introduce the heel coating for the CREDO stent to you and report on our initial experience with the CREDO heel and give some future insights upon the upcoming RECHRUT study on the CREDO heel for acute intracranial stenting. These are my conflicts of interest. So, why coating an intracranial stent for treatment of intracranial stenosis? The goal is to reduce thromboembolic and instant thrombotic events and to promote the healing of the vessel. So this is a scheme showing the primary and the secondary hemostasis. As you all know, primary hemostasis is caused by vasoconstriction and platelet aggregation, and then it comes to a clot formation. And at the final step of this clot formation, the heel technology works, and it mimics this last step of the hemostasis by control of a fibrin network. So the stent is covered by a fibrin network, which is marked green here. And then there's heparin covalently bound to this heparin surface. And this is the reason for the low thrombogenicity together with the antithrombin 3 that binds to the heparin. This is the effect of reducing thrombogenicity, and on the other hand, the fibrin-based coating is a scaffold for interaction with the endothelial cells, and it shall interact with the fibrin via a surface receptor, and then the formation of a healthy endothelium is more likely than with a bare stent. If we look at this in vitro data, that is the basis of the development for this coating. You see 4 graphs. The upper left is the thrombin antithrombin complex. Then the upper right is the complement complex. Then the beta thromboglobulin and the elastase. And if you look at the uncoated stent result, which is always the middle bar, you see that the antithrombin is activated in an uncoated, but much less activated in fibrin-coated or fibrin-heparin coated. Whereas the differences for the complement system are not that big. And if we go to the beta thromboglobulin graph, we see that the fibrin-heparin coated system makes a much better job than the fibrin-coated ones, which is the main reason to go for this combination of fibrin coverage with covalently bound heparin. And this is the Chandler loop system, where you have a tube with circulating blood and a stent implanted into this tube, and then you look at the uncoated stent, the control group with no stent, and the coated stent, and you see that the heel-coated devices have less platelet adhesion and less thrombin-antithrombin 3 complex formation as compared to the uncoated stents. This is an electron microscopic picture. On the left hand, you see the uncoated laser cut stent. On the right hand, the coated laser cut stent. And it nicely shows that there is much less formation of cells on the surface of the stent. These are rabbit histopathology pictures, so in vivo pictures derived from a heel-coated and non-heel-coated Derivo stent. It's a bit easier to examine, as I learned, because there are just more struts, so it's much easier to microscopically examine a Derivo stent than the CREDO stent, for example, because the coverage of the CREDO stent is, of course, very little compared to a flow diverter. So you see the endothelialization And on the left-hand side picture with the uncoated stent, you see a lot of granulocytes, macrophages, giant cells, plasma cells, and the black things in the middle are the stent struts. Opposed to that, on the right side, you see the heel-coated device with a very smooth and nicely formed endothelium and much less foreign body reactions. So less macrophages, less plasma cells, and giant cells. And this is the rabbit model where stents were implanted in both common carotid arteries and in the aorta. And there were two groups compared with bare stents and heel-coated stents. The rabbits were on aspirin and clopidogrel, starting 4 days before implantation, duration lifelong. And then there was a follow-up at 28 days. And this is what you see in terms of neo-intima thickness, and the good result is that there is pretty much no difference between the devices. So the heel coating doesn't prohibit endothelial healing, which could be a matter of concern if you have a coated device that might not well integrate into the vessel wall. So cell proliferation is not impaired by the heel coating, and the endothelialization is equivalent for the uncoated and the heel-coated devices. These are comparisons to other competitor devices in the market, the P64 HPC, the Pipeline Shield, and the Derivo 2 heel. You see on the graph on the left side the thrombin-antithrombin complex with a baseline control tube, and then the three different coated flow diverters, and there's pretty much no difference. But when it comes to the complement system in the right graph, you see that the Derivo 2 heel much less activates the complement system as compared to the P64 and Pipeline Shield. So this is our interim analysis of the CREDO heel and the limited market release phase. We have 14 participating centers. So far, 46 patients treated. This data is a couple of weeks old, so now we are close to 60 patients. 13 of them were treated in Solingen, and this is the Solingen data only that I can show you here. So average data a bit more female patients, and the mean age was 80 to 89 years, and target vessels were, as you would expect, mainly MCAs followed by basilar artery and intracranial ICA, and there were 2 cases with ACA and PCA. Stenosis grade before treatment was 90%, after treatment, after stent PTA, 17.5%, and with this very poor follow-up that we have so far, because these are all recent cases, there are only 4 patients in the follow-up, and there is a 5% residual stenosis grade, so almost no stenosis. And in the whole group, there were 8 rescue stentings and 5 elective stentings. These are the rescue stenting cases, where we had, of course, the TK 0 situation before at the first angiogram, because it were acute thrombectomy cases, and TK 1 and TK 3 after the final stent retriever or aspiration recanalization attempt. 6 out of 8 had a TK 3 score, 2 only 1. And prior to PTA, there was a decrease in good TK results because we waited for 5 to 10 minutes while preparing the balloon and all this stuff. So half of them were re-occluding, which is reflected by the decrease from 6 to 3 patients in the right bars. And this is the final result after stent PTA, where we had good results in all these 8 cases with a full recanalization. The pre-medication, of course, was quite heterogeneous. Some patients were pre-morbid on antiaggregants or other medications, but we had peri-procedural GP2B 3A in the group of the lysis cases, patients in all cases. And if we look at the post-procedural regimen on the right-hand side, you see that 8 patients were on dual antiplatelet and 2 on mono antiplatelet. In the rest of the patients, it was unknown at that time. The follow-up at 90 days is available for 6 patients, and we had a good outcome in 5 patients of MRS 0. And 1 patient was dead at 3 weeks post-treatment due to a COVID pneumonia. 1 died due to a stroke in another territory. I think it was the basilar artery case where the commune carotid artery and both ACAs and 1 MCA was occluded. And there were so far no procedure-related complications during follow-up. So these are a couple of cases. 49-year-old female symptomatic with right intracranial carotid artery stenosis in the cavernous segment and recurrent right MCA territory embolic ischemias, treated with a CREDO Heal 4mm and Neurospeed 4mm balloon. This is the pre-treatment MRI with the scattered DWI lesions and the intracranial carotid artery stenosis with pronounced wall irregularities and suspected adherent thrombus, the predilation with a Neurospeed 4mm balloon and implantation of the CREDO Heal 4mm stent through the balloon. And there is still some material opposed to the level of the stenosis, as you can see. And this is the follow-up at 3 months. She was still under aspirin and clopidogrel, and then we reduced her to 100 milligram aspirin lifelong, and you see that the vessel segment is much smoother than it was before. So the stent did not show any instant thrombosis, neither intimal hyperplasia, but it really made the rough surface of the stenotic segment much more smooth. This is a 47-year-old male with a tandem occlusion of right ICA extra and intracranial, clinically fluctuating, blood pressure dependent, NIH 1 to 6 over hours, and the decision was made to reclinicize due to suspected ICA pseudo-occlusion or an hemodynamically unstable situation. It turned out to be a complete occlusion. It was not a pseudo-occlusion, so we went with a balloon guide catheter and a 3mm Tazuna balloon for pre-dilatation. We aspirated a lot of thrombotic material from the extracranial ICA, and then with an aspiration catheter also from the intracranial portion of the ICA, together with a Aperio 6x50 stent retriever. And the remaining finding was a high-grade cavernosal ICA stenosis just below the ophthalmic origin, predilation with the 3mm Neurospeed balloon, and implantation of a, let me see which CREDO Heal it was. I think it was the 4mm. Yes, it was a 4x20 CREDO Heal, and this is the result, TK3. Astonishingly, the final extracranial angiogram didn't show any residual high-grade stenosis, which we expected. But at the beginning, with the aspiration through the balloon guide catheter, we extracted a lot of sandy and whitish material. So probably we did an aspiration atherectomy from this lesion. So we left it like it was. The intention, of course, was to stent it in the end, but that was not necessary anymore. And this is the 3-month result, with a very low-grade residual stenosis in the stented segment and no intimal hyperplasia. So same procedure, reducing from double antiplatelet to mono antiplatelet therapy. To conclude, the CREDO Heal together with NeuroSpeed double lumen balloon is safe and effective in our preliminary data. Further results, of course, are pending, and we have no insights on anti-aggregation yet, so we treat all these patients as if the stent was not coated. But I guess we will gain some insights on the necessity by special cases where double antiplatelet therapy would be stopped for other reasons or for bleedings or whatever. So far, we only had one patient where there was an early discontinuation of clopidogrel and there was no instant occlusion or thrombosis. So the so-called RECHRUT study for the rescue stenting with the CREDO Heal in the thrombectomy settings will hopefully start soon. I think we just got some remarks from the ethics committee, and that should be solved quite soon. And this study is a prospective single-arm multi-center open-label post-market clinical follow-up study. 15 centers in Germany will participate. The duration shall be about 36 months enrollment and 3 months follow-up. And the objective, of course, is to evaluate the efficacy and safety of acute permanent stenting of the symptomatic intracranial stenosis following unsuccessful recanalization by thrombectomy. And inclusion criteria are evidence of large vessel occlusion, which is upon the operator's discretion. Patients shall be over 18 years old, have acute persistent vascular occlusion due to high-grade intracranial stenosis in the anterior or posterior circulation, so both anterior and posterior circulation will be included, and alternative therapy concepts are not considered or fail. The suspected underlying stenosis of the occluded artery should be suitable for PTA and stenting according to the treating physician's assessment. And the infarct core shall be small to moderate prior to initiation of thrombectomy. So CT aspects 6 to 10, DWI lesion volume less than 70 milliliter. Symptoms onset less than 24 hours before start of the procedure, and treated with a study device following at least one futile mechanical recanalization attempt with a stent retriever, direct aspiration, or combination of both. And pre-stroke MRS should be 0 to 2. Exclusion is, of course, any contraindication according to IFU, and a patient with atherosclerotic probable, according to clinical testing, vessel constrictions, high-grade intracranial stenosis over 70% with significant circulatory disturbances and recurrent symptoms in spite of medical therapy, with contraindication against treatment with any antiplatelet medication, and with current effective use of oral anticoagulants, for example, INR higher than 1.7 or direct oral anticoagulants. The primary safety endpoints is, of course, ipsilateral symptomatic intracranial hemorrhage as defined by the SITSMOST Heidelberg bleeding classification criteria within the primary hospital stay, instant thrombosis, perforation or rupture of the target vessel, and any other device-related procedural complications, grade of recurrent stenosis within 90 days post-procedure compared to stenosis grade after PTA and stenting. And the secondary safety endpoints are ischemic stroke or TA downstream territory of the occluded vessel within 90 days after the stroke, or death or dependency within 90 days after stroke. So MRS 4 to 6 within 20 days. That's it. Any questions? Thank you very much.
So, Hannes, thank you very much. Question from Mr. Bester.
Yeah, thank you very much for the data, Hannes. One question, so what do you personally need in coated stents to change your thinking about anti-aggregation? Because we do quite the same. We use coated flow diverters, took part. And so my hope is just that we continue with the medication and just get less complications in terms of thromboembolic events. But at some point, we, of course, want to change, all of us want to change. So what do you personally need? Like randomized study, or what would make you change your mind?
I think the first step would be to collect all these cases where for any reason the anti-aggregation has been reduced to a single or just stopped. So if we collect all these cases and see good results, it would be nice to go for a prospective randomized study, but I think that will be very difficult in the acute setting. If we look at data for flow diverters, in Val d'Isère there was just presented the P64 series under prasugrel monotherapy, and I think they had almost 20% ischemic complications. So this is really, in my mind, way too high to continue with the mono antiplatelet therapy. And actually I'm afraid that we have to go a long way to decide when not to go for our standard regimen. So, but I mean, our stroke patients are severely ill. Many of them have the need for a reduction of antiplatelet therapy, and so I think we'll gather data from these special cases. So we had, for example, we had a young lady. And she had a hypermenorrhea, so she needed hysterectomy quite soon because she became anemic more and more. She was down with her hemoglobin to 6 or below. She had a high-grade basilar tip stenosis that we treated with a CREDO heel, and she was symptomatic for posterior circulation ischemias 4 or 5 times, and so we said we implant the heel device, and once she needs the hysterectomy, we reduce to aspirin monotherapy. So this is quite recent, and the gynecologists are about to decide when to do the procedure. So we'll see how this works under aspirin mono.
So I'm absolutely with you, and I believe like many of us, or even all of us, have some cases, some anecdotal cases that have been like done under mono anti-aggregation. But like my fear is that when we collect all those anecdotal cases, we will still have a large collection of anecdotal cases and not real evidence. And in the end, I'm absolutely with you. I believe we have to go a long way and to do like a very well constructed study with a high power to overcome this problem.
Yeah. So I think we'll have heterogeneous regimens as we have in flow diverters.
So I think the story gets even more complicated when we talk about flow diverters. Flow diverters have high complication rate with thromboembolia. Atherosclerotic stenting, and the rate of restenosis is between 30 and 80%. So, so I think it will be impossible to prove with such a device for an emergency treatment of atherosclerotic disease that this coating has an advantage. It's much more complicated than with the flow diverters, and. Do you think it's the promise of this coating could be that you have less restenosis, which is?
I guess also, yes.
So, but nobody knows. So
we don't know. We don't know. So far, we haven't seen any, and usually we see approximately 25% of restenosis. Like in the Aclino series that was published, I think by Lucas Meyer, that was a 25% of restenosis rate. And so far we haven't seen any in the CREDO heel follow-ups. Maybe that's another benefit. Yeah, but the interesting question will be: is a 3-month control a bit too early? Because the most severe restenosis that we see are the early ones, and if we follow up 1 year later, many of them are reduced. Yeah. 3 months.
And by angio?
Yeah.
This is like even in the RECHRUT, I don't know how to pronounce the study. So
In the protocol, yes.
protocol, because we discuss, normally we would do our control later, but in the protocol it's exactly 3 months. So is this something that's still open to discussion and maybe changed?
There was a huge discussion on it, and it was hard to agree on anything, because some centers said they never control at all. By no means. Others said, yes, our neurologists, they sometimes control by transcranial Doppler sonography. Others said we do the controls by CTA, because CREDO cleaners, as we all know, are quite easy to be controlled by CT angiogram, as long as they're not in the siphon, in a calcified surrounding. But with the very little opaque material of the stent, we can nicely control them also by CT angiogram. And I guess in the RECHRUT trial there will be old and disabled patients who, if they can show up for control, they might be more eligible for CT angiogram than for DSA. That's at least our experience. But the aim would be to go for DSA control in as many patients as possible. Yeah, so we agreed to try to go for a 3 month control, but there will be a lot of deviation from this, for sure.
Okay, thank you.